would really like to talk to you about respiratory viruses, and I need to get going because I've used up time making a technical issue here. I'd like to start out by saying that I acknowledge that I get research support to my institution from several pharmaceutical companies, mostly involved with vaccines, AstraZeneca, GlaxoSmithKline, Merck, and Pfizer, and I'm a consultant for some other companies related to respiratory virus vaccines. This photo is by my son, and I don't have to acknowledge him. I want to start at the beginning by saying this study results that I'm presenting is by a lot of people. This is just the tip of the iceberg. This is the 15 or 20 or so senior investigators. We have, 3 times that many people in the field that have helped do the work for the study, for the Seattle flu study. It's now called the Seattle Flu Alliance. It is a wonderful group of collaborative individuals from multiple institutions who really have worked hard together to study flu and other respiratory viruses. So let's go back to 2020. This is almost 3 years ago, February 24th, 2020. I can remember it well, but we already knew by January 2020 that there was some sustained transmission in the United States. Not much, some of it coming out of the Seattle area in a nursing home, but the first community SARS-CoV-2 virus detected circulating in the United States that was not related to travel occurred on February 21st, identified on February 29th, and that was in an adolescent from a patient attending an adolescent clinic affiliated with Seattle Children's Hospital. It was a really big deal because at that time, the CDC was not allowing us to test samples that didn't come from people with the contact of a known SARS-CoV-2 person. So it was really a big deal because we discovered this positive sample and we were very limited legally as to what we could do. So let's just compare a little bit about what went on in previous pandemics. The pandemic in 1918 called the Spanish flu or the swine flu really affected a lot of people. The world population was about 2 billion, now it's 8 billion. How did it spread? Well, it took 4 months to get around the world. We think SARS-CoV-2 really happened about 2 days. What did we have for treatment? Masks and disinfectants. What did we have for SARS-CoV-2? Well, we had masks at first, and eventually, and pretty soon, we got vaccines. What did we treat people with? Bed rest and aspirin in 1918 with a huge amount of deaths, 25 or so million. And in 2022, what have we done? We've treated them with antiviral drugs, monoclonal antibodies, and had at least 7+ million deaths due to SARS-CoV-2. So things got better over the next 100 years, but maybe not better enough. If we want to take a look at the current epidemiology as of early November, you can see this is a worldwide problem with 600 billion confirmed cases, 6 million deaths. And interestingly, really importantly, look at the huge number, 12 billion vaccine doses administered worldwide, which is very astounding that we, the public health and health care people, could get vaccines into that many people. Many issues related to that. I don't have time to go into that, but it's still a great success that vaccines were established and administered so around the world. Now, before I finish my talk about the Seattle flu study, I just want to make sure we're all on the same page about our tests, because I'm going to be talking about a lot of the testing we did. And we require diagnostic testing to prove a person is infected with COVID-19. And actually, from the very beginning, we require diagnostic testing to prove someone's infected with influenza or RSV. It doesn't always have to be molecular, but the different tests that we use, and I know that you're very familiar with them, are the PCR tests, which is very sensitive. It can detect RNA or DNA, but the RNA or DNA doesn't need to be replicating. It can be kind of what we call dead. As long as it's there, it is detected. An antigen test is generally done in a nose sample or a saliva sample. It's quick, but it is less sensitive, at least 10-fold less sensitive. And in general, positive antigen tests indicate infection, but not always. And just because one is antigen positive, it's not fair to say that actually there's infective virus in the patient. Now, an antibody test is a blood test. It's a test in general. It's a blood test. It indicates that you were infected with SARS-CoV-2 or flu or whatever specific antibody you're looking for in the past. And it usually doesn't appear until after 5 to 12 days after infection. So there's lots of different antibody tests available now. And I just want to make sure that we have a clear understanding before the talk that there's a difference between detecting the virus by PCR or antigen, or detecting the antibody, which is the human response to the virus. So with that out of the way, I'm going to talk about the Seattle flu study as a prototype pandemic surveillance platform. I'm going to talk about community-based surveillances, response to COVID, and the different studies we as a community, as within the Seattle flu study, have done in schools, shelters, and congregate facilities. So anyways, sorry. Other clinical cohort studies we've done have actually identified potential targets for treatments and vaccines, predicting the immune response, and what we'd like to do is really prepare for the next pandemic, which there will be one. So here's the beginning of the Seattle flu studies, of the flu study. It was about 100 years ago when we started our flu study in 2019. At that time, it was 100 years before or since the last influenza pandemic in 1918. And we all knew, everyone knew another pandemic was inevitable. Most of us thought, including myself, it would be a flu pandemic, but we already knew that there were other kinds of coronaviruses that had circulated. The current surveillance strategies in the United States were not designed and are not designed to detect novel pathogens. So the objective of the Seattle flu study was to develop a pandemic surveillance platform that could be used to identify new pathogens and develop strategies for rapid containment of spread even before a vaccine was developed. Started in 2019. So what was our surveillance approach? Well, the common approach that is typically done by many CDC studies relies on reports from clinics and hospitals. We ourselves do at Seattle Children's Hospital and at University of Washington in-person surveillance from emergency departments, clinics, and hospitals, and take virology results and look at them and report them back to the CDC. However, this really misses individuals in the community who do not seek care and who may introduce novel strains in the community, contribute to the spread in the community, and actually provide an earlier signal of activity compared to hospitalized populations. So we wanted to know, can we identify individuals with flu in the community who do not seek medical care? Can we diagnose and treat flu at home? That was our original thoughts. So our strategy was to expand to the community and build a high throughput lab. So we set up sites for testing all over the place, as many as we could find. Schools, workplaces, even transit centers, the airport. We studied novel ways for us to do home testing without having a person to come to a clinic or a treatment site, which nowadays that's all kind of simple. We have county treatment sites and hospital testing, but back then that was really new. And we wanted a high throughput lab that could detect multiple viruses at a time at a sensitive level and also to detect novel pathogens. We wanted to be able to merge clinical and lab data quickly, identify who is at risk, and understand the spread in the community. So that was our goal. And this is perhaps a busy slide, but this is what we did the first year, 2019, the fall of 2019, going into winter 2020. We had, here is our central site, our hospitals, UW, Kaiser, Fred Hutch, and Seattle Children's. And then we went and established surveillance for people in homeless shelters, here on the left, various schools. We got a lot of support from the Seattle Public Schools, Hutch Kids, daycare centers, Bush School, etc. We got help from the CDC to help do surveillance at transit centers, the airport. We also had other sites, work sites such as Costco. We had CMAR, a wonderful healthcare clinic, mostly based in West and South Seattle, as well as the University of Washington itself. So the community enrollment was, we had these cute little booths set up. People could self-refer to a kiosk. Eventually, we actually had people being able to phone in or screen over the phone. We'd screen for eligibility by our group. We would get consent, signed consent. We'd have a consent questionnaire. We'd have a questionnaire asking about symptoms on a tablet. A nasal swab would be collected. Initially, we collected them. Eventually, over time, people collected them themselves. The patient would turn the sample in, drop it in a drop box, put it in the mail, send it back via FedEx, whatever, and eventually the person would get a gift card and would get the diagnosis of influenza. Remember at the beginning, all we were looking for was influenza. We had web-based apps where we were trying to have people enroll online, either for longitudinal studies or just for a one-time sampling. And this was actually quite popular because back in 2019, 2020, there wasn't much rapid test available. And we developed the swab and send study. And I hope maybe some of you were involved in this, where we actually had swab and send. You could fill out your survey after enrolling online. We would send you, or we maybe already had sent you a box that had a swab, tell you how to do it, show you a video, and the person could, you, the participant, after signing consent, could get a sample swab, screw on the lid, put the label on it, and we would pick it up with a rapid delivery express. Then, once we got the sample, we would test it for 26 different human pathogens. Now, remember at the beginning, this is pre-COVID. This was pretty exciting. Having the Brotman Beatty laboratory run currently by Leah Starita was a real advantage because with a very small amount of fluid, we could do a rapid molecular testing of all kinds of viruses, from RSV, flu, paraflu, rhinovirus, measles, pertussis, all of these. We were not allowed, based on state law, to report everything back, but viruses that were approved by the state for this test, which included flu, could be reported back to people eventually. And then we'd let people report their results. Novel. Nowadays, you think, well, that's not so novel, but 3 years ago it was. So what happened in the 2019-2020 season? We were able to track the evolution of influenza A, the virus-specific type called influenza A H3N2, using the molecular detection and then doing sequencing using a platform developed by multiple people, Debbie Nickerson and Trevor Bedford at Fred Hutch, Debbie Nickerson at UW. And using this platform, we could actually sequence the virus and find out where the different influenza viruses came from going to Seattle. And the orange circle here is more of Seattle, but you can see that we had viruses coming to us from all over. Normally, we would have thought most of it would come from China in the purple. But here you can see that a whole lot of it came from the rest of the United States. It came from the eastern United States moving west. We also got samples from Asia moving east, and we got samples from South America moving north. Building on that, we thought that we could do home antigen testing. That is, people could self-test at home, and if they were positive, we could give them an antiviral for influenza. And this was a big effort run by several of our graduate students. It was really a fun study where we enrolled a whole household. We sent them weekly text messages asking if they had flu symptoms. If they did, they got to use a home test called an Illum test kit, which actually tested for flu A and flu B. They would get a telehealth consult to confirm that the swabs were collected right. We would send the swabs to our molecular test to confirm it, and we'd send them via FedEx or whatever rapid transit. We'd send them the home delivery of a flu antiviral. For adults, we used baloxavir. For children, we used oseltamivir. Baloxavir is a one-time dose. Oseltamivir, you take it twice a day for 5 days. So this was really an exciting concept. It was new, it was novel. I just want to say the bureaucracy to get this through all the administrative hurdles was astounding because none of this had been done before. And it worked. We used remote household-based approach to flu testing and antiviral treatment. And we used that in December 2019, January and February 2020. Now, what happened was by 2020, March, flu was going away and COVID was coming in. So perhaps our numbers were not as high as we wanted, but we still developed the testing and strategies for this method. So what did we learn from community surveillance? We learned that community-based surveillance identified the pathogens early. We were able to take steps to prevent transmission by giving antiviral drugs and letting people know what they had. It takes time and effort to establish community relationships. That is true. And it's important to establish biospecimen repositories that are linked with clinical data. Just getting a sample or just getting a survey doesn't help. You have to be able to link it. Contactless methods to diagnose and treat is really important. That way we can get people in the home before they're really sick and not require them to go to a doctor's office or a hospital. But this has to be in place before a pandemic, because once a pandemic starts, it's really hard to get it established. So while in the midst of our flu study, SARS-CoV-2 came along. And here's the first slide I showed you with SARS-CoV-2 being detected in a Seattle Children's Hospital patient in February 2020. We had enough surveillance ongoing to show that we really know when it started. And then over the next 2 months, we were able to really show that there was sustained transmission of SARS-CoV-2. This graph on the right shows it by age group. You can see that the 20 to 59-year-olds had the most SARS-CoV-2 tests. And then here on the bottom graph, you can see the number of tests with a positive result. The first test, which was right about February 21st or 24th, the patient actually had 2 tests. You can see that it just started picking up a number of tests, starting 1 or 2 and then going up to 6. And it just mushroomed from there, as you all know. So here's the national timeline of events. Helen Chu, Trevor Bedford, and Leah Starita are all in this wonderful comic strip that was designed, showing that there was a first U.S. patient in January 21st, 2020. We knew that was a patient that came from China, known exposure in China, showed up in Everett Hospital, was treated there. CDC was involved. Everybody knew about it. We began our discussions on the next day to see if we could do testing from our flu study. There were a lot of issues, mainly by the FDA, saying that we couldn't give results to patients unless we had approval by the CDC. The CDC had a test that wasn't very good, and they wouldn't do our testing. So we had a lot of problems. But by February 25th, we received permission to test samples from the Seattle flu study. And 2 days later, we had a positive. It took a lot of talking over the weekend with us, with my hospital, with us Seattle flu investigators and the FDA to develop a clinical pathway to actually report results to patients. So the first detection of SARS-CoV-2 community transmission in the United States was really part of the Seattle flu study. By that time, in January to March, we had over 2,000 people enrolled. 1% had COVID detected, but only a quarter of these sought care for their illness. So in other words, we were capturing 75% extra stuff. From June 2020 to January 21, we did 32,900 tests, of which 2% were positive, and only 8% sought care for their illness. So by doing community surveillance, we can find a lot more cases that are generally missed in hospital-based surveillance. So just a couple pretty pictures showing what Trevor Bedford and the sequencing group were able to show. We were able to sequence the first 400 or so SARS-CoV-2 isolates from Washington. Again, here's the country that they came from. And of course, most of them came from Asia to begin with. And we actually looked at the number of mutations that developed over time. And you can see that's how you can distinguish different SARS-CoV-2 viruses from one another. The Washington isolates are all in orange up here, and they really had multiple mutations compared to the Chinese virus, but they did have mutations that allowed them to be distinguishable. And that's what we used to trace viruses. And that helped develop the different strains that we now know as, Alpha, Delta, Omicron, etc. So COVID-19 arrived in Seattle. Where it went stunned the scientists. There have been a lot of papers and interesting articles and a lot of publicity about this. It was a lot of work by our group and by many people. And the bureaucracy we fought during this period was really, really intense. New York Times reported on this. 2 cases detected weeks apart in Washington State had genetic links. Helen Chu was featured in one of these papers. It was really a lot of effort and things going on at that time. So what did Seattle contribute besides identifying the first samples? Well, we actually enrolled the first patient with SARS-CoV-2 to get antibodies. We enrolled him to get serum. This man was incredibly gracious, and we actually were able to go collect multiple samples. Good thing I'm a pediatric phlebotomist because I'm good at drawing blood. But after we were exposed, Helen and I were both in isolation for 2 weeks and monitored closely by King County people. But what's important is that the blood we drew after getting permission from the person infected really was the source of monoclonal antibodies that have been used for prevention and treatment of new monoclonal antibodies over time. And this resulted in multiple papers, and this blood was distributed for free, not just to the NIH, but to multiple universities and hospitals. And that really helped accelerate the use of serum and monoclonal antibody prevention and treatment. So what did we learn during our early response? The problem is, what is the distinction between research and public health? Public health activities are exempt from the common law, which governs human research subjects. And that was a very big problem for us. Can we take a research activity and then make it into a public health activity? Well, we should, and we did, but we didn't do it as soon or as smoothly as could have been possible. We need to have flexible consents. We worked so closely with the IRBs, the institutional review boards, particularly the University of Washington Institutional Review Board, that agreed with us that having a potential pandemic virus overrode the exact wording of the consent form. And with that and getting ethical consultation, we were able to actually report results back to patients and families earlier, perhaps, than would have been possible otherwise. So here's the question. Is it ethical to withhold results of a test that could potentially alter the course of an individual's illness and society's trajectory? This is what we were dealing with. We had a sample with a high viral load. We confirmed it was positive, but there's no widespread testing available. What if the individual got sicker and infected other people? What if there was an old person or cancer patient in the home who could really get sick? However, our lab was not CLIA licensed. It was not FDA approved, and we were not permitted to return results because we could have returned perhaps an unvalidated research result. Now, interestingly, samples collected through the hospital didn't require consent, and people were doing that, but they weren't giving results back to the individuals. This resulted in a lot of discussion among our group, and I just want to say that many of us investigators, including those here on this group, Michael Beck, Helen Chu, Tina Lockwood, Debbie Nickerson, Jay Shindra, and Leah Starita, we all felt that regulations hindered pandemic surveillance. And this is one of our editorials in Nature of Medicine, a very good journal, really showing that we tried to show people how we could have done better if we didn't have all the regulations. So the rationale for human cohort studies are that we really need clinical specimens, we need transfer of specimens across boundaries, and we had an ongoing research study from Seattle Flu Study as well as the Harvey study, which is the study ongoing at University of Washington. So we had samples all available. We just needed to be able to get them analyzed and potentially reported. So we were able to immediately assess new variants. We showed that they consistently occurred. We're able to show here's our different codes for beta, alpha, gamma, delta. And I don't want to go into the details, but you can see here that at the very end, you could see that there's consistently new variants always popping up with these green. This is showing delta in the summer of 2021. And then we had, by December 2021, we had the Omicron variant, which led to explosive growth. And this is through the University of Washington's surveillance study. Despite 99% vaccination in college students and maximum use of non-invasive masking and non-pharmaceutical interventions, we still had lots of Omicron virus, meaning the vaccine was not as good as we thought against Omicron. not going to go that. We also were able to explore long COVID. That is, people having symptoms of COVID relating to, commonly fatigue, loss of taste or smell, and all those things you can see on the x-axis during the acute illness. So we are involved with many others at the University of Washington in studies of long COVID. It really is a problem with many, many healthy younger people. They get over it within 6 months, but about a third of people continue to have symptoms. And this was publicized and all over in the newspapers. There may be multiple factors from some of our studies that may increase chances of long COVID, perhaps autoantibodies, viral load, pre-existing underlying conditions. It's still not totally clear and studies are ongoing. So from our human biorepository, what lessons did we learn? Well, we learned that studies are difficult to set up during a pandemic. We kind of thought that. It's important to have prototype protocols, which we had for flu, so we were able to institute those and just change them a little bit. It was important to have a hierarchy for specimen distribution. Who gets which sample first? Really important. The CDC always wants their samples first, but they were so overburdened they couldn't do the testing. So we needed to have contracts and methods to transfer samples and see what test and who and which lab did it first. And then the funding is really important. The funding takes so long to go through our administrative bureaucracy at our universities that having unrestricted funding for rapid scale up was really helpful. And some of our funding was obtained through the Gates Ventures group that really did help us move ahead quickly to set ourselves up well. This is an example of the testing we did at the University of Washington. It's called Husky coronavirus testing, where we enrolled over 20,000 people and people could get tested anytime they had symptoms. The strategy was you could self-refer to a kiosk or sign up online. If eligible, you got informed consent, you completed an app-based questionnaire, and then you got a supervised self-collection of a nasal swab. And what this data allowed us to do was to assess the rapid appearance of variants. And in here, you can see the Delta variant is in blue, the Omicron variant is in yellow. And even though some of our earlier graphs showed the Omicron variant coming in mid-December, by using the Husky testing, we were able to show Omicron variant actually appeared really in the first week of December. We had good viral diversity. I've shown you this before with the blue being Omicron. And from this, we were able to have even more comparisons comparing Omicron to Delta viruses, showing here that compared to the Delta viruses, the people that had Omicron viruses had a shorter interval of time cases in the household. So if it was your house and you had Omicron, someone else in your house was likely to get the virus and be infected 2 days later compared to 6 days later with Delta. The Omicron had a higher reproductive number, that's an R0 value, but the Omicron also had a lower viral load than Delta. So this was really an interesting finding that we could do because of the studies that were in place. We also did school studies. We had great access and collaboration from several schools. The Seattle Public School absolutely helped us with many of our household studies. The Snohomish Public Schools helped us with a prospective comparative study doing home-based versus school-based testing. In this study, we also did a study looking at children with autism. We were trying to get all parts of the outpatient population. And this study, Masking for Children with Autism Spectrum Disorders, was a study done by Ben Aronson and colleagues at the University of Washington. We really wanted to show that kids with autism or ADHD, this is pretty severe ADHD, can mask consistently. And this was a very carefully tracked interval data showing that kids can wear masks even when they have disabilities. Now it helps if you have stickers and really motivated teachers, but this was back in 2021. This was important data as we went into school-based masking. We We also did a study in the schools to try and see which viruses are present on the surfaces. We did school surveys when kids had gone home looking at high-touch surfaces from plastic, metal, and wood surfaces. This paper by Dr. Alex Murray, currently a fellow here at Seattle Children's Hospital. And we really found that lots of viruses are commonly detected on surfaces, but especially rhinovirus. That rhinovirus can survive a long time. And these viruses that we did detect, rhinovirus, RSV, flu, some coronaviruses, these viruses were very similar to those infecting children in the community. We did SARS-CoV-2 screening testing in the Snohomish schools. We were able to show here, if you can look at this top line, that school-based collection was a much better way of getting samples than home-based testing. It was really parents that volunteered to have us test their kids. We got about 90% weekly surveillance, whereas people who did it themselves, whether they were students or teachers, it kind of went down over time as people got tired. Aaron Chung did this study. Here's the going down over time. We also did studies in homeless shelters, a really high medical need condition, including homeless shelters for adolescents, homeless shelters for women and children, and homeless shelters for men. And here's one example of a large homeless shelter early on, and you can see they sleep on mats about 2 feet or 1 foot from one another. And you can imagine that viruses and disease would spread relatively quickly in these shelters, even though people are only in the shelters usually about 10 hours a day during the night. And the people who are red and yellow are the positive cases, and you can see if a red person here had a case, we often found a case nearby. But not always. Here, the desk person got it. That desk person was probably seeing everybody. Here, 2 next door neighbors got it. And then another person got it a couple weeks later. This is tested positive by PCR. We did these tests by sending people to the shelters, being pleasant and allowing free testing as their time permitted it, not forcing anyone to get tested, but then actually giving a $5 gift card if they did. We have more studies showing the genomics of the severe of SARS-CoV-2 in emergency shelters. And I think our group has some of the best molecular data about homeless shelters, showing how fast things spread. But actually, there was no more spread in the homeless shelters than we were actually seeing in the community. We didn't limit it to SARS-CoV-2. We are actually able to look for the seasonal coronaviruses, that's the non-SARS-CoV-2 viruses, and found outbreaks of the community coronaviruses. We found rhinoviruses circulating in the homeless shelters. And I just want to say these are a lot of work by a lot of people, including this is by Dr. Eric Chow, now at King County Public Health Service. And then I just want to make sure that I have a few minutes to talk about vaccines, because we all know that preventing disease is better than treating it. It's more effective, it's more cost effective, it's better for the people, it's better for society, and it's better for our healthcare system. And I just want to say that we've had incredible success with individuals and families participating in vaccine research at University of Washington, Fred Hutch Cancer Center, and Seattle Children's Hospital. I can basically speak more about the Seattle Children's Hospital. And these are our children who are pretty much smiling, not all the time, but they're smiling. It helps to have stickers and Legos a lot. But these kids are really brave people, and their families are heroes for spending 3 to 4 hours at a time to get their child have a vaccine and answering our weekly diaries. So why do we need a vaccine for children and adolescents? And we had one for adults at this time. You know about this. Certainly the high priority was in the older adults who had a higher mortality rate. And some people were saying, oh, we shouldn't have vaccines for children and adults, children and adolescents, because they don't get that sick and they don't die. Well, they do get sick, they do die, just not as much as older adults. So we do know children can transmit SARS-CoV-2. We have, of the known cases, about 10% are in children, and the indirect consequences of COVID-19 in children have been devastating, and you know that. shutting down of school, increased mental health visits, total isolation, and I think in particular, our mental health services in the state of Washington and in Seattle have been overwhelmed. And I'd like to really mention that the ethical principle of distributive justice expresses the ideal that benefits and burdens should be distributed among society in a just manner, meaning that children should not be excluded. And I'd add on to here, pregnant women are a similar population, as are hard to reach minorities, as are homeless people. So we knew that there were many things that would influence pediatric immune response to vaccination, but really intrinsic host factors and extrinsic factors were the ones that really we thought were going to be the most important. Age, sex, comorbidities, and then antibiotics, and if the child had pre-existing immunity. The first study we did was a Pfizer vaccine trial with an mRNA vaccine in 6-month to 4-year-old healthy children and 5 to 11-year-old children who are randomized 2-to-1 to get the Pfizer vaccine compared to placebo. And then once EUA was obtained, everybody who got placebo did get the Pfizer vaccine. And the first study published in New England Journal of Medicine showed that the 5 to 11-year-olds who got a 10 microgram dose did as well immunologically and clinically and protection-wise as the 16 to 25-year-olds who got a 30 microgram dose. So the Pfizer vaccine in the 5 to 11-year-olds was pretty easy. We gave them 2 doses and things went well. What happened to the 6-month to 5-year-olds? This was a little bit messy. We gave them a 3 microgram dose, and unfortunately 2 doses of the 3 microgram dose wasn't good enough. Even though there was excellent safety, the decision was made with consultation with the FDA, the company, and investigators that really a 3-dose series was going to be needed in those children under 5 years of age, which was a real disappointment because 3 doses is hard to give, right? So the new plan was the 3rd dose was to be given 8 weeks after dose 2. We had multiple of these children. They came in, they got their blood drawn. Same thing was going on with Moderna. Moderna actually got licensed for 2 doses as a primary series, but Moderna really does much, much, much better with 3 doses. So currently, the COVID-19 RNA status for children and adults is really quite good with 18-year-olds having 3 vaccines available. All 3 vaccines have provisions for booster doses, and these booster doses include the bivalent booster. The 12 to 16-year-olds also have availability of getting the bivalent or Omicron booster dose as of September. The 5 to less than 12-year-olds have a 3rd dose approved by ACIP in May, and they had their bivalent booster dose under EUA in October this year. So above 5, all of these people have multiple vaccines to choose from, multiple booster doses, and they all can get the Omicron booster. But our kids under 5 are still having a little bit of a problem. We're a little behind. We are actively doing the studies. We're working as hard as we can. And the bivalent booster dose is now under study. We hope to have results available by early 2023. In addition, we have immunocompromised children receiving a 4-dose series with a bivalent booster under study at this institution. So how to implement COVID-19 vaccination in children? Well, first you have to have an approved vaccine, and that's really difficult. Next, you have to have recommendations by government, medical organizations, schools, have the vaccine available. That has been a problem, but we really quickly caught up. And then we need to have widespread publicity and education for families. What I want to just show is a couple slides from the Seattle Public Schools setting a model for success. And there's going to be an MMWR paper coming out soon with the people from the Seattle Public Schools and the CDC showing that a multi-pronged approach is needed to partner with the community. You have to utilize on-site vaccine administration and education with nurses and personnel who can speak the language of your students. You need assistance from the principals, teachers, and staff who actually promote this. And we work with local healthcare providers, including regional and local experts, including the Othello Station Pharmacy, which has a Somali-based distribution, and the Seattle Urban Indian Health Clinic. The Seattle Public Schools have pioneered and really done a huge amount of work with multiple weekend clinics with free access, not just to COVID vaccines, but to flu vaccines. And I just can't say enough that has really helped increase vaccination rates in this school. And this is ongoing in other school systems too. What we can say is that this article in Press showing that we have much greater increase in all ethnicities and populations of the COVID-19 vaccine series in those children ages 5 to 11 as over time as school-based vaccination increased. And the bottom line is, if you look here at the total, it's really close to 80% getting vaccinated by June of 2022. Really amazing. But what is the problem? We still continue to have problems with our diversity and with reaching certain populations. We have an immunization rate in the Seattle Public Schools over 90% for Asian, down to 70% for Pacific Islander and 58% for those in grades 9 through 12 who are African American. This is not acceptable. We need to do better. And this data is courtesy of Sammy Hogue and others from the Seattle Public School nurses. In those ages under 12, grades K through 5, we have a similar finding with decreased vaccination by ethnicity group. So what's going on now? I quickly want to say this is what's happened. On the left here, you can see all we had was this blue COVID and a little bit of gray rhinovirus. And then what happened? In May 2022, we started letting up our guard a little bit. And by the time school opened in September 22, we were having all of these viruses. And right now we are at our hospital and in the state and in the country, we are just inundated with RSV, some of the highest rates of RSV that we've ever had. RSV may be on its way down a little bit, but flu A is on its way up. So we are still having lots of respiratory viruses, but not that much COVID. If you look here, the community respiratory viruses are back, and it's back with a vengeance. And you can see here as of November 2022, we are just flummoxed. We are overburdened, and our population is, over 100% occupancy. RSV, if you look at just specifically RSV, we had RSV, the virus respiratory syncytial virus, in 2019 and 2020, and then we missed. It was lovely. We missed it. And then October 2022, we got a little bit, October 2021, we got a little bit more of it. And now, I don't have it on this graph. Now we're just crammed full. Our ICUs are full. Our emergency departments are full. Our urgent care centers are full. So I'm going to just go through this. RSV hospitalizations right now are about 32% higher in 2021. This is based on surveillance that we in Seattle are a part of for the CDC. The kids are older. We're seeing hospitalizations now in kids over 12 to 23 months of age, as well as those up to 5 years of age, mainly probably because they haven't had RSV. We've had 2 or 3 years of kids not being exposed to RSV. So high rate of RSV nationwide. And influenza is here. This year is early and it's bad. So you know that. October 15th, look at green is good, red is bad, black is terrible. You can see here it's really bad in the south. This is as of November 5th. And if we had a new one today, we would be starting to turn orange. So getting flu vaccine is important for us to say. As part of the Seattle flu study, we recommend everyone get the flu vaccine this year. There's newer vaccines and better vaccines for older people, those over 60, as well as for those who are egg allergic. Flu vaccines can be given at the same time as your COVID-19 booster. You give it as 2 shots, just in 2 different arms. And generally, the side effects are similar if you get 2 shots at once or versus just 1. I just have a few minutes. I just want to make sure everybody knows that we are having problems with our vaccines in general. Children are getting behind on their routine vaccines. It has and will increasingly lead to outbreaks of things like measles, pertussis, mumps, etc. This is a problem. I would like to conclude now with saying pandemics have a huge impact on society overall. The terms of suffering, the economic problems, the mortality, the burden to high-risk individuals, those of us working in healthcare, and those already socioeconomically at risk has been immense, and I can't spend enough time talking about that. However, we need to be prepared to detect a pandemic early in order to prevent severe sequelae. Diverse networks need to be funded. They need to be funded from the government for public health, schools, universities, clinics, hospitals. It can't just be several university studies, and the Seattle flu study alone is not enough. COVID-19 vaccine and flu vaccine will help prevent infection, disease, and spreading, but we need to increase our vaccine uptake, especially in high-risk people and in diverse, underserved populations. And finally, with the booster bivalent COVID-19 vaccines now approved for children 5 years and older, we need to get people to take it. And we need to finish our studies for those under 5 years of age, like this little girl. So I've already said it takes a village. I just want to make sure you know that we have a lot of people participating who have worked night and day trying to get this study and these studies going, to get them data analyzed and to get them published so that the rest of the world can appreciate what we are doing here in Seattle. I'd especially like to acknowledge the Seattle Public Schools and the nurses, Ms. Hogue, Kearns, and Anderson, as well as the Public Health Seattle King County people, Sarah Regal, Bell, Graff, and Cozio. But also my research group. This is my research group here, led by Kirsten Lacombe, Sarah Vora, Alpina Wagmar, and Amanda Adler. We have a huge number of people. I can't name all their names, but I just want to say this is a big effort by many people. And I appreciate your attention. I want to thank the children who participate in this, and I have a few minutes for questions.
Perfect. Thank you so much. Some comments in the chat. You were in the right place at the right time with that study. Um, and an additional a question here for if you're going to keep doing surveillance testing in the schools and homeless populations for ongoing data, and do you see where there will be a home test for influenza as we have one for COVID?
So number one, funding is what drives this. We're going to try and do as many studies as we can, but we have to write grants to do this. We do have one study that I should have put the slide in for that. It's called the Cascadia study. And this is a really interesting study. We'd love you. You can go to Cascadia. And Stephanie, I could even send it to you. But it's a multi-center study between Portland and Oregon where people can sign up and get free testing weekly, but you have to do it weekly, for flu, RSV, and COVID over a period of 4 years. And we're trying to do this. This is a study that is trying to enroll 4,000 people and go for 4 years as part of a government effort to do ongoing surveillance. And that is what we need to be doing to really capture a new pandemic before it happens. Because we think we have to do it in the community, not just based on what's going on in the hospital. The hospital just takes so long. So the Cascadia study, you can email me about it, janet.england@seattlechildrens.org, or you can go online on Google and look for cascadia.org. We have lots of websites, and we're looking for people to sign up, families or households that have to have at least 2 people in the household. But we are not doing much of the other studies, in part due to limited funding. Although we're writing grants, and we'll try and do as much as we can.
Thank you so much for that. And just to be clear, there is no RSV vaccine in development, or right? Or
let's talk about RSV.
one that exists?
Yeah. I don't know. Can you see me and not the slides, or I don't know what you're seeing?
Yeah, I can see. Yeah, I can see you, but not their slides.
Perfect. Well, what's totally exciting is there is an RSV vaccine, and it works for at least for older people. And there is an RSV vaccine for pregnant women, which will help prevent RSV disease in babies. They're not licensed, but I believe within the next year, we may have an RSV vaccine, not for kids who suffer the most, but we think we may have an RSV vaccine. There's actually 2 companies that have had successful trials of an RSV vaccine for those individuals over 60 or 65 age. And the RSV vaccine in pregnant women, the unofficial results are out, and I don't know how much I can talk about it, so I won't, but it really is good. The idea being that if you can immunize a mom with an RSV vaccine, she can provide antibody that will protect the baby for the first 3 or 4 months of life, which is the highest rate of hospitalization and medical care for babies. So our group is working very hard on RSV vaccines. I've been working on it though for 30 years. I've never been this positive about the fact that I think RSV vaccines will be available relatively soon. And others are working on mRNA vaccines for RSV. So, I think over the next 5 years, there's going to be a lot of opportunities for preventing RSV, at least in many of the population.
Oh, that's wonderful news. Um, and I'm curious, I think you said that, children have not been exposed to RV because of school closures and whatnot, but there were some areas in the United States or certain populations like daycares where they did stay open, so that, because they didn't have people to care for them, especially in daycare centers. So were those kids still exposed to RSV during that time, and would
There was
not
no
necessarily
RSV.
because of the
There was no RSV in the world. I mean, there was not RSV in Australia or
oh,
South America, or I mean, where did it go? And there must have been some, but there sure wasn't much. And we didn't, in most of our tracking, maybe we had a couple cases a year. We're getting, 100 a day. And I'm saying, so where does it go? I think it probably goes to
yeah.
the tropics, maybe where it just kind of is indolent all the time, but it wasn't in temperate climates in Australia, in New Zealand, in South America, Canada, United States. There just wasn't RSV for almost a year and a half or almost 2 years, even in daycare.
Mhm. Wow,
Wow.
that is really, really interesting. Um, any other questions for Dr. England? It's a lot of feedback. Thank you so much for the great work and presentation. Okay, so one more. You mentioned that the Moderna vaccine is much more effective after a third dose for kiddos under 5. Children's currently offers just 2 doses. Do you know if parents can request a third one through Children's? I don't know if that's what you're asking, Rita, or
Um, I don't know. The answer is I don't know. And then Rita
Mm,
says through the Children's Vaccine Clinic, soon there's going to be I don't know, but I expect within the next 2 months that the bivalent's going to be available for everybody. So you might just want to wait for the bivalent because that's going to be better than a third dose of the monovalent. Right? It's
mhm.
now December. I don't know, but I don't know. I hope by February we'll have the bivalent ready, February or March. I mean, we are trying so hard. We've enrolled, 100 kids in our study here. They're getting their blood drawn right now as we speak. Pfizer is analyzing the blood overnight. So I know people keep criticizing all of us for not being further along, but this has been the most fastest and smoothest vaccine introduction for children of any vaccine we've ever had. So I think it
Mhm,
is good, but it's not good enough. We need to get the
mhm,
bivalent booster out there for kids. That I believe is
mhm.
a high priority.
Yeah, I definitely think the response has been really quick and robust given the lower rates of admissions for children with COVID, um, too, and given, compared to what we're seeing now with RSV and flu. So, I mean, I think it's been really great. And I'm hopeful that, like you said, more vaccinations will be coming along because the more on top of it we are, then, we can prevent diseases from spreading. So, thank you so much for all of your work and your team as well.
Thank you. Thanks for having us and letting me
All
represent
right.
my group here.